Good morning, everyone. Today, we are very honored to have Dr. Passakorn from Thailand here. Dr. Passakorn, do you mind introducing yourself to the audience, please?
Thank you, Jerry, and thank you, the HaploX, for inviting me to this session. My name is Dr. Passakorn Wanchaijiraboon. I am a medical oncologist, and also I'm a vice director of the Prapokklao Hospital. Prapokklao Hospital, that is around 900 beds. We responsible for the 2 millions of the population. The Prapokklao Hospital is very near to Pattaya. I think many of the Chinese may know the Pattaya more than my hospital. And but in my area, we have very much a famous fruit. We are in the area that send the durian to your country. We are in the main of the durian export to around the world. And so in my area that in my hospital that I responsible for the vice director that of the hospital, responsible for the AI and medical innovation. And another hat that I do in the Thai Medical Council. I do the jobs that responsible for the AI and also the genomics and also for the other purpose of the Thai Medical Council. And the job that I do in the my hospital is because my hospital is a excellence of the cancer centers position in Thailand. So we try to develop our own genomic labs. We starting the first for the just only the PCR, like EGFR mutation in the lung cancer from the blood and also from the tissue. And the next step is we run the NGS of the germline BRCA and also the multi-panels. And I have to say that we are very proud that we are the first genomic centers in the governmental hospital that can run it. We run it for 3 years. The number of the patients is not quite a lot. We run now today is only the 400.
Still a lot.
Of the specimen that, but we try to push more effort to do more multi-panels of the. But I have to say that we still have the lack of the personnel like bioinformatics and also the technician. So we need to have another friends like HaploX, to send out our specimen to have another test for the patients because we know that the NGS will be the answer. It can give us many answer to the patients. We have much more like a VAF. To reach for the VAF to make a decision like in the recent study from the last year. I think like a stage 2 and 3 of the colon cancer that if the patients have got the PIK3CA mutation, they need to have adjuvant aspirin more than only the chemo because they just only the 2 tablets of the aspirin per day for 3 years can reduce the mortality, the recurrence rate to 50%. So that is the reason why I think the genomic centers and the genomic testing in the cancer patient is very essential. Thank you very much. It's not brief thing, but I think it's quite. That is the reason why I'm very interested in the genomics. It can help the people a lot.
You're really like the pioneers of like pushing the NGS into Thailand.
We try.
But it takes time and also it's a long progress for us. Even like in the Chinese market, we also spend like I think nearly 10 years to really to educate not only the doctors but also the patients about the importance of NGS, like why patients need them, and also like why doctors need them, and why like the laboratories need them and the technicians need them. So it will be a long progress, and I'm glad you are like we invited you, have you here as the really like the frontier and also like the pioneer of pushing NGS.
And the barrier of the NGS is the main problem, I think, not only the technology, but also the price.
True.
I have to say that the price of NGS a few years ago is very high. Right now, I think it's 50% discount, and the HaploX is very. I think it's very interesting because you provide us many more data and various of the data with the price is very low. So not quite low, but the patients can access to this NGS. So if we just like open the doors to the others.
Yeah, I see.
Thank you.
Yeah, HaploX works with our own in-house developed reagent kits and also our own software. So that allows us to bring down the cost to a very cost-effective price, and also not compromising our quality.
Yeah, that's right. Thank you.
So speaking of policies, may I ask, like, what has been the biggest bottleneck in truly implementing the clinical genomics? And could you share a specific lesson learned or another breakthrough that you inspired of?
Oh, thank you very much. It's very important questions. And the answer is about the single biggest. The bottleneck has not been the sequencing technology at all, but it has been the last mile, the getting a genomic result. And that translates into an actionable clinical decision. It's the main things, because when we have the result, we need to push it into the clinical and we have to put it into the patient, right? And I think that this pushing this result into the patients that actually changed the patient management. So early in our program, that turns around time for the tumor sequencing is the key, because I have to say that at the beginning point, we have the turnaround time is 3 to 4 weeks. I think it's very late. So, and it may be late for the patient also. By that point, the oncologist has often already made treatment decision made on the conventional pathology, not on the genomics, because they cannot wait it for the genomic result. So the genomic data arrive too late to influence the first course of the actions. I think this problem of the turnaround time is very generalized around the world, because in many of the guidelines of the lab need to reduce the turnaround time from to 2 weeks, and the best is in only 1 week for the result back. So I try to restructuring our molecular tumor board. We invest in a rapid reporting pipeline where the bioinformaticians and also the clinicians are co-located in the same workflow rather than in a separate silos. But I have to say that molecular tumor board is quite very different, and it's quite difficult to set it up, because in my hospital we don't have the clinical geneticists. So we have to consult to the academic hospital like Sirilat Hospital. And Dr. Manok, he is very important KOL of the genomics in Thailand, because he runs the Genomic Thailand. He is the PI of the Oncology part in the Genomic Thailand. And so I have to mention him because I think he is a very important person in Thailand that can push the policy and also to push the genomic data into the patients. So the other things that I have to say that we also the standardize of the variant interpretation tiers using the ESMO SCAT guidelines. So the report can carry a clear therapeutic implication, grading, then the turnaround that can drop into the 10 days. And right now we can run the EGFR because it is very easier to do it. We have only less than 7 days. So we can run it every week. And the lesson that I share most often of the genomics implementation is only the 20% of the sequencing. But the 80%, I think that is a workflow interpretation culture and also the clinical integration. And the most impressive breakthrough was not a technology at all. It was persuading the oncology team that a genomic result without a therapeutic pathway is noise, not signals. And the clinicians start pulling the molecular tumor board into treatment, planning and routine once they trust the output. So I think the lab is the important one. But the clinician is also need to integrate into the process. I have to say that the genomics technology is quite very advanced in these 10 years. So the clinician that is a graduate more than 10 years, they have like a re-skill and also to relearning about this process and to relearning about the technological terms. And so the continuing the molecular tumor board is need for every hospital that using the NGS or to have the genomic testing.
Of course,
Yeah,
of course. So I think not only like the sequencing technology is not like the bottleneck, but like the people's knowledge or like the background knowledge of the.
Yeah, I think we have to develop together. I see that the technology is more advanced and a very big leap, and the price is lower from day to day. But I think in Thailand, because of the NGS, before this day is quite high. So the numbers of the NGS testing will be quite a little number. So when we have more data and more knowledge, I think we will have, the doctor will have the confidence to send it and to interpret it and to apply it into the patient.
I see. So I think NGS, like the situation of NGS, is kind of similar like the AI situation, like for the general public. Some of the people will utilize the AI to in their work or in their daily life, while some of the people are afraid that AI might leak their data or might be misleading in their general work. So I think NGS will kind of similar situation like in the oncologist and also the clinicians as well.
Yes.
So well, speaking of AI, what do you think? Like, what would be the position of AI in like precision medicine, and also like the genomic development?
Very good questions. I think we know that in every like a generative AI, that right now that is a large language model, like a DeepSeek, and I have to say that every brand. And even with a B2B, like a Claude or Anthropic, they still have the hallucination. I think everyone knows that. But the latest data is the hallucination that the clinician concern is about the medical hallucination. Do you know that if we send like a CT scan of the chest to the Gen AI, it can interpret to be liver.
Really?
Yeah, that's right. And the difference of the medical hallucination is depends on the brand of the
the
AI.
brand. Actually.
So that is the reason why of the many brands of the Gen AI have to put the new product like a medical AI. Like a ChatGPT that they have, the chat for the healthcare. So I think the genomic AI is something like that. Because of the AI intelligence depends on the data that they learn, and depends on the teacher of them.
True.
So I think every regulatory body in this world, they still have to regulate the medical AI as a co-pilot. I think that every platform, and so we still, even we have the medical AI to help us, we need the authorized one. Authorized one that is correct or not correct. The important thing is about when the medical AI or the genomic AI assist genomic interpretation, we still need a post-marketing surveillance. Like when you launch about the genomic AI help. So I think they still have hallucination.
I see.
But the inconvenient truth about that, we know that we need the authorization. And inconvenient truth in the research paper, in any paper, is like, that right now we have a problem about using the AI doing the research paper. Like in New England, the latest one, the New England Journal of Medicine, they just have the paper that generate the pictures from AI.
Like in the prefix, like oh my God.
I think that is very lesson learned for everyone. Not even by the New England. That the New England Journal of Medicine is very quite.
It's like the top tier, right?
They're very top tier. So it can miss, or maybe it's intentionally missed.
Probably.
Maybe intentionally missed to everyone to raising the concern about that. So I have to say that. Even we know that the AI can make the hallucination, but we still have the less restrict because we believe it. We cannot trust it 100%.
I see. You have led several international phase 3 clinical trials, and what is the most easily overlooked factors and for successful multi-center research in Southeast Asia, and what are the good solutions are currently available for this problem?
Okay, thank you for this question, because I think the clinical trial is an important part to caring of the cancer patients because we have to know that the cancer is very resistant. Even in the stage 1, they can recurrence, right?
Yeah.
So the most overlooked factors is regulatory harmonization at the protocol level. I have to say that the assumptions that the ethical approved process, the informed consent standards, and also the data transfer agreement will work the same way across countries. But they do not. Like in my and our experiences of protocol amendments that approved in other countries, they also require a full resubmission in Thailand and a separate national ethics committee review. So these add to 4 to 6 months of delay per cycles, and the trial sponsor based in Europe and or the US, maybe in China, routinely underestimate this. But this is a problem of Thailand. I have to say that in Malaysia, it's quite very different.
Oh, really?
Because right now we have to know that the clinical trial is very competing across the countries. And Malaysia is one of the top that can reduce the time for the ethical process. And they have a template of the MTA and CTA.
Okay.
That is very important things. The Ministry of Public Health and also the Ministry of taking care of your university, they try to push the template of the CTA and also the MTA to reduce this process. And we have a national CRC and to try to reduce the process of the ethical approve. But it's still ongoing to do these jobs. And the most critical but invincible bottleneck is a germline data governance.
Of course.
I have to say that many Southeast Asian countries currently have no explicit framework for the cross-border transfer of the genomic data. This creates a situation where a trial is scientifically sound but legally unexecutable. The best available solutions include first is using the local PI as a regulatory navigators and not merely recruitment sites, but also doing the jobs as a PI as the other side. That they must be empowered to engage directly with the competent authorities. And the second, that the ASEAN harmonize the technical requirement for the pharmaceutical products, offer a partial framework for the regulatory alignment. And the third is for genomic data and a federated analysis approach, where the data never leaves the country but algorithms are shared and are increasingly viable and bypass many sovereignty concerns. Singapore's precise initiative and the Thailand's Genomic Thailand programs are the beginning to use this model for population genomics.
I see. So like not only each country have to participate or like to push these trials and also like the regulations, but also it takes like inter-country like forces to make this study to make happen.
That's right. Because I think in Europe, they're joining.
They have the European Union.
They have European Union, and they use this opportunity to push the trial together, so they can recruitment of the patients very quickly. But I think in China, because you have a very big population, you know that mainly of the trial right now, I think from China. But I think China and Thailand, we very share the genomic data.
Yes.
I think maybe I'm a half of the China.
Oh, really?
Because my grandfather sailing from China to Thailand. Many of the Thai population, I think maybe they have Chinese genomics together. So I think that the clinical trial that we can share from China, maybe Thailand to China from one belt, one road, something that I think it can make easier and rapidly recruitment process.
Definitely. Like all Southeast Asia countries need to work together to make this happen.
Thank you.
So after we speak about dry lab, let's talk about the wet lab things. So what is the most easily overlooked technical bottleneck when bringing genetic testings into the real life routine clinical practice? And what experience does Thailand have in establishing the regional quality standards?
Well, thank you very much for these questions, because I have problem about that.
Okay.
Yeah, because I have to say that the most overlooked bottleneck is a pre-analytical variability. Yeah, the gap is in sample handlings before the specimen ever reach the sequencer. The FFPE time in the surgical pathology is the crucial things, and the transport temperature for the liquid biopsy samples. I encounter about a few samples that I don't know why invalid. They turn to invalid from the NGS, but I don't know why the liquid biopsy cannot interpret. Yeah, so right now we have a solutions for that, because if the FFPE is more than fixation time, I think more than 48 hours, because I run the clinical trial. The requirement for the FFPE fixation time is less than 48 hours.
40 hours.
Yeah, for the most, I think the most favorable time for the DNA and also the RNA. Yeah, but the problem that I found is some of the pathology that have fixation time more than 2 weeks. That is because the lack of the medical personnel to cut it.
I see,
and to bring it from the formalin.
Formalin and
the formalin. Maybe it's quite look very easy problem solving, right? But I think it is a neglecting things. So after we know the problem, we recruit more the medical personnel. So this problem is solved right now.
That's good.
But I have to say that the problem about the liquid biopsy temperature is still big, because some of the liquid biopsy that I sent internationally, because in Thailand we have many of the provider of the transport. I'm not quite sure that they have like a quality assurance of the transport of this specimen, because I still see the problem about the liquid biopsy.
Hemolysis.
Yes.
Coagulations and other things.
Yeah, and so I think we discovered in one of the NGS validation study in my center that is 23% of the discordant result between our center and the reference lab. Yeah, then were attributed to the difference in the formalin fixation duration. And not sequencing errors. And this invisible in the standard quality report, which typically evaluate only post-sequencing performance metrics. So for the bioinformatics, variant allele frequency threshold and reference genome version are two additional overlooked parameters. Variant codes at 3% allele frequency with the GRC H37, and the alignment may be filtered out or annotated differently under GRC H38. Multi-center studies that do not harmonize the bioinformatics pipelines upstream will produce the non-comparable downstream result. And Thailand experience in quality standard and has developed primarily through the Thai Red Cross and the Department of Medical Science. So, and this quality approved have to build an ISO. Typically the ISO will apply in the labs that do the lab. But I think they did not cover of the lab that cannot do lab. Only transport. So I think we have to raising a concern of this quality. Even you send the pathology out. So we need to have the quality improvement that you prepare the pre-analytical part so well, and we need to push this problem to be a performance indicator of that center. So it can improve of this problem of this bottleneck.
I think probably even though we don't have such a regulation, but we can start with some consensus. To establish. And also it's true actually very hard for NGS, because even though we have some of the the normal QC values like the Q20, Q30 and there's duplication rate, but still we are still missing some of the big puzzles as you said, the time when they make the slides, and also how is the bioinformatics pipeline are they analyzing, and even their reference, like what reference version, what the human genome reference version they are using, and also like the threshold they are filtering out the mutations, and also there are different LODs, and there's a bunch of stuff there. So we're still like in a long way to really to harmonizing or like to normalizing the NGS testings for clinical.
Yes. So I think the communication part between the genomic labs and the clinician is very crucial thing. And not only the clinician, also the pathologist.
Yeah, the pathologist.
We need to have maybe a quarter or every 3 months to have a meeting that, okay, you do your job so well, and this is invalid. I think the clinician and pathologist need to know why this is invalid.
Yeah, exactly.
It's not just only the result invalid. We need a hypothesis. That's why. So when the pathologist and the clinicians see that, so we can improve the process for the next specimen.
Exactly. Okay. We need to debug together to find the problem and then to solve that together. It's not like a one-man job, but like it's the whole team to do it. Yeah, exactly.
Thank you.
So Dr. Passakorn, you were speaking of liquid biopsy. So may I ask, like liquid biopsy, especially MRD testings, is considered as a next breakthrough in precision oncology. So what do you think, what is the key evidence gap still need to be filled before MRD can really become the routine testings for solid tumors? And what methodological issues should Southeast Asia countries be considering solving this problem?
Okay, thank you for this question. It's very important because the MRD is very important. The MRD is a substitute for the minimal residual disease because in every patient that we taking care of, or the cancer patients, we want them to cure the cancer. The question is why the stage 1, after we cut the cancer off, we use the adjuvant treatment. Why it's recurrence? The one that postulate is about they have this cancer cells or the ctDNA already in the blood. So for the technology right now of the liquid biopsy that we can detect that ctDNA. So the main problem for applying the ctDNA in clinical practice is about it. Can the ctDNA, the ctDNA positive is the prognostics to the recurrence, or if we intervene of the MRD positive patients, like giving the more chemo, giving the targeted or giving immunotherapy, that is translate to the overall survival. That is the key things. So we know right now that we have that signals more and more, and I think the most applicable data is in the bladder cancer.
Bladder cancer.
Because after you using the cut it off and using the adjuvant, if the ctDNA, when you operate to the bladder cancer and they have the MRD positive, when you use the immunotherapy, after that it can change the survival. So that is can put into the guidelines already. But the problem about the using the MRD testing of this guideline, because they have something like a component testing in only one brand. Only one brand that they have in the US, in the state, and the price is quite high. So in my opinion, it's something like the first EGFR testing in the world that they use only the COBAS technique. Because the COBAS technique that used in the EGFR clinical trial. So they have the component test. Right now, we know that. Only you have a PCR of the EGFR in any brand, so you can use it. I think in very next futures, if we can do the MRD testing that have already comparable to that brand. We will have another MRD testing, and the patients can get it, can get this more
benefits.
And the other cancer that have the signal of the ctDNA testing can signal of the prognostic and predictive factor is in colorectal cancer and in the breast cancer. I think in every cancer we have that signal. So we the things right now we need to do is we need to do more jobs to have a good RD and have the clinical significance after the ctDNA positive to be more applicable in the clinical practice, and that can translate to the overall survival of the cancer patients. And then for about the other words, it's about the CTC, the circulating tumor cells. I have to say that it may be more difficult to do the lab. So right now it's in the research. So for my conclusion of the MRD, I think it's very promising, and we will see many of the consolidated data and using the MRD. So our job have to do is cheaper and cheaper. So the patients will have the less barrier to this testing. Thank you.
Yeah, that's true. That's true. Actually, yeah, because MRD not like showing its technological advances in monitoring the recurrence for cancers, but also it's gaining its prominence in the guidelines. So as you speak, the bladder cancer, the MRD has already been into the guidelines. And also I heard that recently in NCCN guidelines, the pancreatic tumors, the MRD is also was recommended for I think for one of the drug, like if the pancreatic cancer patients are tested MRD positive for the specific for the MRD, they are eligible for doing one certain of the target therapy as well. So I think we are making our way to the MRDs.
And maybe I'm not sure that is the easier or the difficult part. And when I think the hypothesis of positive MRD may consistent with the recurrence rate. So when we do something, it will change the people life, the patient life. So if we can do the clinical trial that prove it, we need to be more clinical trial. And if any doctors that interested in MRD, they need to contact to the company or to the labs that you can make more and more data about this. It will help other people a lot.
It's like the previous question we talked about. It's all about the synergy between patients, doctors, and also companies to make it happen.
Yes, and the other things that I would like to say is about, I'm not sure that the MRD in the Western and in the Eastern will be the same, because like in cholangiocarcinoma, I have to say that because of the cholang in the Europe, there we have like a targeted, we have a mutational, like IDH1, or they have but not found in Thailand. In that paper, the Thailand Clinical Trial Center involved it, but we don't see any actionable mutation
in the Western ones.
In the Western world. So it may be the MRD from the Western and the Eastern may be quite different.
Sure.
Yeah.
Because like every time when we found when we diagnose the liver cancer, it's already the late stages, and which includes many kinds of mutations. Not like the breast cancer or lung cancer. It all started like the majority of them start with an EGFR mutation or like BRCA1/2. But liver cancer is like a whole bunch of different mutations. So and also especially like liver cancer are highly related to lifestyles. And well, in my perspective, like alcoholic consumption is one of the key factors that affecting the difference between the Western populations and the Eastern populations. Like for for the Chinese population and the Thailand or Thai population, because Chinese population they tend to consume some of the high alcoholic proportion of the liquors, which make liver cancer one of the most high incidence rate in China. So I think definitely MRD need to take this into consideration, like the different lifestyles and like the difference between different regions.
It's very important data I think the ethnic variability will be the other things that we have to be concerned. The last thing is about the tumor informed and also the tumor naive.
The tumor naive.
Yeah, because of I think each cancer patient is different. Because we know that the tumor can have heterogeneity. They can have 1, 2, 3 or more the mutational signature in the patient, in each patient. So I think the tumor informed is very important. It is the issue that you need to do the tumor informed and to find out which this patient have every mutation when you design the probe for this specifically. Because the main problem is when you say that MRD negative, it is truly negative. We don't know, right?
Exactly.
We need to very carefully to do the tumor informed, to try to find out every mutations that the patient have.
I see.
Thank you.
Thank you so much, Dr. Passakorn, for your opinions and also your valuable knowledge. And thank you very much.
Thank you very much, and thank you, HaploX, and thank you, Cherry, for every questions and every answer. I think it will be valuable and informative for you. Thank you.
Thank you.
Thank you.